Hi, I'm Dr. Julie Gralow, the Chief Medical Officer for the American Society of Clinical Oncology. I'd like to thank the conference organizers for this important Choosing Wisely, Avoiding Wisely meeting, for inviting me to speak on de-implementing low-value cancer care, the role of oncology organizations. As I thought about what I wanted to say in this talk, I thought, we have different strategies for improving value in cancer care and optimizing appropriate use of drugs, treatments, and diagnostics in cancer. One, we can reduce low value care, the topic of this conference. We have our Choosing Wisely campaigns that address this. We can also at the same time increase high value care, balancing efficacy, toxicity, and cost. We've got ASCO and ESMO value frameworks, and we've got our World Health Organization essential medicines and essential diagnostics lists. And we can also at the same time work toward defining and monitoring what is quality cancer care by using evidence-based, resource-stratified guidelines that are used to tailor to the individual situation care pathways. And we can use quality monitoring and evaluation techniques and tools. So just a little background on the Choosing Wisely campaign. It began in the US in 2010 as part of the Obama administration's efforts in healthcare reform. And there was a paper published at that time, 2010, by Howard Brody, entitled Medicine's Ethical Responsibility for Healthcare Reform, the top five list. And in that editorial, he wrote that regional variation in costs in the US suggested that nearly a third of healthcare costs could be saved without depriving any patient of beneficial care. So within a couple of years, the American Board of Internal Medicine launched the Choosing Wisely campaign, and they asked their member medical specialty organizations to identify tests and procedures and practices that were commonly used, but whose necessity should be questioned or discussed. And we got at least 80 different independent Choosing Wisely campaigns targeted to each organization. And the Choosing Wisely mission was to promote conversations between clinicians and patients and help patients choose care supported by evidence that's not duplicative of other tests or procedures already received, that's free from harm, and that's truly necessary. So a big part of this Choosing Wisely campaign was about patient conversations with clinicians and shared decision making. And I think we've lost a little bit of that main point of why we were going this direction. I've put in this slide and the next slide ASCO's Choosing Wisely list. In 2012, we came up with our top 5. Don't use cancer-directed therapy for solid tumor patients when it's not going to work or offer benefit. Don't perform imaging scans for staging early prostate cancer or early breast cancer that's at low risk for metastases. Don't do routine surveillance testing for breast cancer that's been treated with curative intent in an asymptomatic patient. And don't use white cell stimulating factors if there's not a high risk of febrile neutropenia. So then the next top 5 that came out the next year focused on antiemetic drug use. Don't use really potent, expensive antiemetic drugs if your regimen has a low risk of nausea, vomiting. Don't use combination chemo and metastatic breast cancer. Use single agent unless you really need a rapid response. Avoid PET and CT scans as part of routine follow-up care to monitor for cancer recurrence in asymptomatic patients treated with curative intent. Don't routinely perform prostate-specific antigen tests in men with no symptom of the disease. And don't use targeted therapy unless that targeted therapy has in the tumor a specific biomarker that predicts its response. So those are ASCO's Choosing Wisely top 10. We've updated it as recently as 2021. As you all are well aware, many other countries, many other groups have come up with their top 10 list. So a couple of years ago, ASCO came up with a position statement on addressing the affordability of cancer drugs. And while this position statement was really focused on the US and high-income countries, I think it's applicable much more broadly. Some of the key statements were that value-based solutions need to be patient-centered and evidence-driven, that oncology professionals need to define optimal care and provide a framework to assess the comparative value of cancer treatment options from a clinical perspective. We stated that there should be a real and a consistent relationship between the value of a drug and its cost. And while physicians don't control the price of drug, we do determine how drugs are used, and we're accountable to use those drugs appropriately. At our ASCO board retreat in March of 2020, we spent a couple of days addressing our strategic goal number 4, which is make a global impact. And 3 of the major breakout topics were how can we make a global impact in international education, global access to essential treatments, and international leadership development. Out of that retreat, we sent a survey to our international members across 20 countries, and we asked, how can ASCO add value to you, your patients, and cancer care in your country? They rated different categories of activities, 1, 2, 3, and access to essential drugs came across as the top way that ASCO, this professional organization, could add value, with registries, help with registries, and help with pathologic diagnosis coming in close second and third. As a result of this, our members telling us that they want help with access to essential medicines, we were a convener of an Access to Essential Cancer Medicine Stakeholder Summit at our annual meeting this past June to bring together all those working in the area and start some dialogue, make sure we all knew what each other were doing. This was our framework as we started that stakeholder summit. Defining high priority cancer drugs is critical to getting access. We need to define value in the WHO Essential Medicines list. Then you have the access issue of affordability, and then accessibility. Are they included in budgets, national cancer control plans, insurance? How do we procure and transport the drugs? We have the quality assurance piece of getting access to drugs, regulatory oversight. We've got the appropriate delivery of cancer drugs, the healthcare workforce and the health systems infrastructure, making sure we have chemo safety standards. And then we have optimal utilization of cancer drugs through guidelines and pathways, availability of biomarkers, the WHO Essential Diagnostics list, and then monitoring and evaluation programs. So with respect to avoiding wisely, choosing wisely, I think from a professional organization standpoint, we can help with the defining the high priority drugs and the optimal utilization of those drugs. Indeed, ASCO as well as ESMO have devised value frameworks back in the 2015 era by emphasizing clinical benefit, toxicity, and cost. It's the ESMO magnitude of clinical benefit scale that is now being used by the WHO Essential Medicines list. Both of these value frameworks are intended to be objective measures of the magnitude of clinically meaningful benefit of cancer treatments. The WHO Essential Medicines list helps us define our high priority cancer drugs, and they state that essential medicines are those that satisfy the priority healthcare needs of the population and that they should be accessible in sufficient quantities. They're selected with regard to disease burden, efficacy, safety, comparative cost effectiveness. We've had updates in 2015, 2019, most recently 2021 to the essential medicines list that includes several higher priced products such as immunotherapies. The Essential Medicines Cancer Working Group has defined that curative treatments have the highest priority based on their delivered benefit. And the threshold of benefit that was adopted back in 2019 is that there's a 4 to 6 month survival benefit and that they have certain ESMO magnitude of clinical benefit scoring that rates fairly highly. So here's an interesting recent paper that looked at how does the WHO Essential Medicines list align with what our frontline oncologists are telling us are their priority medicines. And this paper also asked, are these medicines accessible in routine practice? So first of all, the 20 most frequently selected high priority cancer medicines in this study, 19 of them were on the WHO essential medicines list. And there was actually quite a high concordance, 75%, among oncologists from various countries across different income levels on what the high priority meds should be. The proportion of respondents that indicated universal availability of these top 20 medications varied by income level. Quite high availability in the high income countries and a broad range, but low availability in the lower income countries. And then there was a question about the risk of catastrophic expenditure for each of these 20 medicines, which was quite high in the low and middle income countries and quite low in the high income countries. And access to these drugs seemed to be less about actual availability of the drugs and much more about the affordability of the drugs. So the conclusions were that major barriers were found in access to these top rated essential cancer medicines. And there's an urgent need for global as well as countrywide work to ensure that all patients with cancer have access to these high value, high priority medicines. Another way that professional organizations can play a role in avoiding wisely, choosing wisely, is to define optimal cancer care and to help with appropriate utilization. To that end, ASCO, which has clinical guidelines across a variety of cancer topics, started an effort a few years ago in helping work with our members in resource limited settings on having resource stratification of our guidelines. So we've since published palliative care, resource stratified guidelines, cervical cancer, colorectal, ovarian cancer, and hopefully within 6 months, we will have a metastatic breast cancer resource stratified guideline. Now, the point of these guidelines is that each individual country cancer center setting would take these under advisement and then modify them into a care pathway that makes sense in their own environment with their own set of resources. ASCO has a strong investment in quality cancer care. And this is another way to define and then monitor optimal cancer care and appropriate utilization. So we worked with the Community Oncology Alliance on developing what we call oncology medical home standards. So we had a multidisciplinary expert panel of clinicians, healthcare administrators, and patient advocates that did a systematic review of evidence, looking at peer-reviewed studies, studies of clinical pathways, review of survivorship care plans, and we developed a set of what we call our oncology medical home standards. ASCO's now taken that and created a pilot that we're calling our patient-centered cancer care certification, or APC4. And we've taken 17 oncology medical home standards, 22 chemo safety standards, and we put it into this pilot focused on patient-centered care. And we are working with 12 practices spread across 88 sites and 2 payers, where we're getting automatically out of the electronic medical record and billing how these sites are doing. And the different categories that we're looking at that are part of quality care are patient engagement, availability and access to care. Are they giving evidence-based treatment, equitable and team-based care, quality improvement, goals of care, palliative and end-of-life discussions, and chemo safety? So this is an ongoing pilot of those 12 practices. I think at least 10 of them have now been certified in this pilot, and we're looking to expand. And what we're going to have to do is prove that by getting certified and working toward these standards, that we actually are improving the value of care at the patient level. And that's high income. I've been asked to talk about low and middle income choosing wisely, avoiding wisely. We have branched out, and through our Quality Oncology Practice Initiative, we have some pilots going on in low and middle income countries. So this is taking some of what we learned regarding quality measurement and reporting. We have a reduced measure set selected by the country that we're working with. The first step is to identify gaps to see what's going on at the present, and then start the path toward quality improvement. Here you see a picture of the Uganda Cancer Institute and Dr. Jackson Oram, their director, who was a leader in piloting this quality initiative. We also have a pilot in Honduras and are about to start one at our International Cancer Corps site in Sarawak, Malaysia. Additionally, we're committed to quality, and in June, we signed a memorandum of understanding with the World Health Organization that's totally focused on value and quality cancer services as part of universal health coverage. And this is our two outputs that we signed in our MOU. We're going to prioritize and align quality indicators. I mean, that's all based on what is value that can be used in WHO tools and ASCO activities. We're going to start with breast and palliative care. And output two is to have studies summarizing policy or programs in response to quality improvement that we can disseminate through WHO and ASCO networks. So we are committed at the global level to help work on improving quality. So de-implementing low-value cancer care and achieving access to high-value cancer care for all is going to require a lot of work, including the following. Collaborative efforts. We need to work together to define value in cancer drug treatment as well as other treatments. It's going to require that we follow evidence-based guidelines, choosing wisely, and prioritizing higher value treatments. We need better communication about treatment options and costs and financial toxicity with our patients. We need to improve the transparency of pricing approaches. We need to collaborate on information sharing, regulation, and procurement. We need value-based research exploring optimal drug dosing once approved, schedules, treatment duration, and the tumors and situations that are most likely to benefit. We need a healthy generic and biosimilar drug market. We need competition to help us with the prices. And we need to continue to invest in biomedical research so that we continue to have appropriate incentives for research and development of our cancer treatments at the same time. So with that, I will close and thank you for inviting me to discuss choosing wisely, avoiding wisely, how to de-implement low-value cancer care and the role of our oncology organizations. Thank you.